Earlier it was like you put the scope to the right side, feed the trunk on the left side. But now, whether it's a VL or DL, it is in the midline. You introduce the scope in the midline, and then the dictum is ulnar leads to epiglottis. Okay. So debriefing. So debriefing will be there, like what they did, why they did, and then fourth will be, motivation to get involved into the discussion. For everyone should speak. Like it is not like I am just concentrating on one person. Or one person is very excellent, please donate to the discussion. So please see into the simulation session when you are training, you go to everyone. Everybody should participate. That is more important rather than making expert one person. Everybody should. It is a social event. They say simulation is a social event. So he should speak like diversity, equality, and inclusiveness. Okay. So everybody should speak. Maybe he will speak one sentence each, but make sure all of the nurses, all of the EMTs, they are speaking. So it should not be dominated by one single person. We see sometimes when we were students, monitor he is speaking all the time. For one person, the teacher will come, he will say, yes, you please stand up and tell us these things every day. So one person should not dominate the discussion. Then we have to find the performance gap. What are the performance gaps? Like he has done very well, he has not done that well, and he has done pretty bad. So what are the reasons for performance gap? Okay, and is it like cognitive, psychomotor, social, maybe under stress? Like they have different kind of reasons. We don't go into those details like Americans or UK. They go so many details, their personal reason. So, but we have to find why they are performing bad. So we have to find the performance gap. And then lastly, we must help them to cover up those performance gaps. So this we have to do with a honest intention. Otherwise, things will not change. If we just come, I speak, you listen, we go back our own ways, nothing will change. So we have to be very enthusiastic, cheerful. So I see America, any workshop, they are very enthusiastic. They are very cheerful. But here, like, we are not that enthusiastic. It's not like we don't want to be happy or cheerful. But still, you put a very good face and you should be enthusiastic that we are learning new things. But here, compulsions are different, like professionally also, from the government side also, on the personal front also. They are pretty free when they come for the workshop. They don't have any other work. But here, you are in a workshop, but getting continuous call from the hospital, from anywhere or from everywhere. So these are the 6 things, like when you are holding a sim session or simulation session, then you must take into account. Then a word between andragogy and pedagogy. So pedagogy, like we ask students or children to go to school. So they don't have any intrinsic motivation. Like it is extrinsic only, extraneous. Like you tell them, go to the school. They don't have any idea why they are going to school. But here in andragogy, you have an idea. Like I am going to this training because I want to take care of my patient in a better manner. I want to have a good position in the society. Like he can treat that much the patient. He can treat very complicated patient. So he will have to go and get the training. So andragogy, there is a motive, there is a motivation, right? Intrinsic, like you want to get better. Extrinsic or extraneous, like society will recognize you, your peer will recognize you. So motivation is very, very important. Okay, then the candidate comes with some kind of expertise. Like you are doctor, you have some expertise. So basic assumption is that you are not fools, you are not novices. So whenever we are teaching with senior person or with some expertise, we have that basic assumption. So have that kind of respect. It is, if you don't any answer, doesn't mean that you are a fool or you don't know anything. Right? So basic assumption has to be there that you are dealing with people who has good degree. Maybe they are not expert in the field you are asking question, but otherwise they are quite well read, they are treating patient and they have good reputation. To have that basic assumption, like sister Agi, hey, ye nahi aata, like take a high quality compression. What are the components? What are the components of high quality compression? बताओ 1 2 3 4 5. हाँ आप एक तो आओ खड़े हो जाओ आराम से. लेट्स हैव ए फोटो. 1 2 3 4 5 बताओ. हाई क्वालिटी चेस्ट कंप्रेशन. ओके, क्योंकि नॉट चेस्ट कंप्रेशन है ना. अंग्रेज बड़े वैसे ना वो कहते नहीं हाई क्वालिटी करो तो चेस्ट कंप्रेशन करो तो इट्स ओके. बट नहीं, दे फाउंड आउट people are doing just chest compression, and I am very surprised. I am not surprised. Whosoever comes to me to register Dr. Jyoti MBBS, nobody still now knows how to do a CPR properly. This is a tragedy in India. Doctor doesn't know. Sometimes they don't know. They know CPR. Sir, BLS नहीं आता, CPR आता है. The level of ignorance we are suffering, I mean, it is enormous. So it is not this session. We have lot more things to do at various level. So like it's not like we are asking you. वैसे भी नहीं होगा, है ना? Because but we keep doing तो इसलिए we keep refreshing our memory. We press the refresh button. So press refresh is by a book by Satya Nadella, है ना? Hit refresh. तो keep hitting your refresh button. बीच में ना मोबाइल में देख रहा हूँ. तो what are the components of high quality compression? 5 now you please Google. Cognitive weight. हाँ बताओ. Press hard, press fast. 100 to 120. Okay. Second.
1/3 of chest.
Okay. Depth. 5 to 6 centimeters. Recoil very good. Yes.
And
Fourth.
lower border of sternum.
नहीं वो तो है. I think there are 5 components. Recoil हो गया. Press hard, press fast. Adequate depth. Then recoil. Ventilation. Not more than 1 second. Don't overinflate. Vomiting. There are 5. So if you don't know,
Minimize the interruption.
minimize them. Not more than interruption. Like if you are doing a focus. Not more than 10 seconds. So if you don't know, just Google. So I want you to get that thing into your muscle memory कि हमारे पास नहीं है तो we will go and any one of us किसी को भी आप बोल दो कि भाई please Google यार what are the components, है ना? So andragogy. So I will just discuss the so that was my the person is Michael Knowles who has described the andragogy. So we have intrinsic and extraneous motivation, and we must have basic assumption. So there are other stuff also, and we can. I mean, you can read about these andragogy. Now, skill learning. So yesterday I was saying, I did the skill. Somebody came. He just took the driver needle and started doing the skill. But I don't know whether that person got that step to the muscle memory, or if we ask him after 2 or 3 days, he will be able to remember or do it. So without immersion, without getting things into the brain circuit, there is no use. So when you are teaching skill or learning skill, there are four steps. So that is known as experiential learning of David Cobb. So in 1984, David Cobb described this. Earlier, you follow patent approach. People hate people see. Patent is the old one. Okay, but David Cobb is the recent 1984. So what he says, active demonstration, like he is the instruction, he will demonstrate a skill. So that is known as active experimentation. Okay, so the candidate will see the skill. Yes, he has performed the skill. The second is reflection. So candidate will reflect. ये ऐसे है, इस तरह से हुआ है. Reflect like if you have come to the training, we will say reflect about the training. How was this? What was discussed? And reflect it was good or bad. So they will reflect. Then in the third step, they will have some abstract conceptualization. कि यार ये टीबल ट्यूबरोस्टी पे था, एंटीरोमीटर सरफेस पे था, और यहाँ पर ये होता है. Like he will have his anatomy knowledge, whatever. So he will have some kind of abstract. Like you watch a movie, आपको थोड़ा सा you have some idea. ऐसा कुछ था. So in skill also, in third step you have what? Abstract conceptualization. It is not concrete. It is not final. You have some idea. It was done with this landmark. And then fourth is active experimentation. Then you do the skill after these three steps. So I will request all of you, whenever you are teaching or learning, please follow these 4 steps of David Cobb. Okay, so first is active demonstration. I'm forgetting. Second is reflective thinking. Third is conceptualization, abstract. And fourth is active experimentation. So we will follow these 4 steps when we are learning or teaching skill. So it is not only for me, for nurses or EMT, whosoever. These are common topics. I thought we will take up these topics also because generally we don't talk these things. And I've seen in all the courses, they come, they start teaching skill. So didactic teaching is different from the experiential teaching. We must understand, all of us, even ATS people, I have seen, it's didactic. They come, they teach skill like as a didactic lecture. Video dikhaya? No. Skill learning, skill teaching is experiential learning, and these 4 steps has to follow. Otherwise there is no use. It is not lecture, didactic lecture. Okay. So that's we observed yesterday. Then cognitive load theory. 20 slides, 30 slides, in one slide, 20 lines. This is not done. Like when we are teaching, especially when we are teaching with novices. So when we are teaching, we have to understand, are you expert or you are complete high advanced training, or you are novices, like you are new one. So there you have to define accordingly whether you are novice or expert. So what is cognitive load theory? Like it is said, like we have working memory and the long-term memory. So our working memory, when we are listening, we are learning, our working memory is active. So whatever we listen, we try to get into our working memory. And then after, what is known as chunking. Chunking is like there is a chain, 1, 2, 3, 4, you chunk together, then you throw it into the long-term memory. After you get those things into the working memory. But what happens when they are cognitive load, overload, like we have 20 slides, in each slide 8 lines, 160 lines, then it is cognitive overload. Like it has been seen, not more than 5 to 7 things one can accommodate at one time. It has been seen, okay, by various studies, by the teacher study. So there is a very good book, Why Knowledge Matters, by J.R. Harsh. So there are few books you must read to make your thinking better, wider and intuitive. Lot of books are there. Okay. So they say not more than 5 or 6 or 7 things. Not more than 7. Like if I give you number 2, 5, 6, 7, 8, 11, maybe you will be 2, 3, or 5 or 4 at one time. After 5 minutes. So they have done those kinds of experiments. So my point is that let's have very few slides and more stories to tell. How we manage the patient, how we formulate the guidelines, how they formulate the guidelines. So it will be better if we tell stories, not the presentation. Because again, it is there everything is there on the internet. Everything is there. You don't have to bother, you don't have to write. Okay, just listen and try to get into the muscle memory. So we must not put cognitive overload to students. So what happens when we put cognitive overload? Working memory is a limited capacity like your phone. So when you are throwing too much into the working memory, it gets filled up. So whatever next information, because there is no space, it will spill over. Means without getting into the brain, the information you will listen and will spill over bits, it will not get into the working memory. If it is not into the working memory, it will not get chunked, it will not go into the long-term memory. So then you don't get anything, you don't remember anything, you don't learn anything. So our purpose is not solved. So please say to it when you teach junior, or especially novices, teach them 4 or 5 things. Like our purpose here is, like let's say we will take 10 things which are workable, doable in our field, in our clinical area. Okay, so just remember that we don't bombard them with too much information, with too many, theories or guidelines or recipes, not too much. Sometimes too much is bad. Okay, then now you have come for the workshop. We must give a pre-workshop assignment. Like if we say surgical crime, so we give you like CIC, some vocabulary also. So what is can't intubate, can't oxygenate? Vocal cords, maybe velicola, maybe a scalpel, a bougie, and then a blade, handshake, three-finger technique. Okay. So these kind of vocabulary we give you. We give you this bougie picture, scalpel picture, like 11 number blade, not 23 number, and maybe then we'll give you weekly show to capnograph. Okay, this is the way that you confirm. So this is more than 3 workshop assignment. We do that. We give you 3 workshop assignment. You read that. You have some information. So when I say when you do surgical crime, you will say CICO, CICO Sudha, you know. When there is can't, when I say CICO, so he has some information. CICO means can't intubate, can't oxygenate. So that kind of workshop assignment should be given to all of us. I mean, especially to nurses, so that they have some understanding when they come for the workshop. It's not like they are like totally like Alice in Wonderland. They don't know what they are going to teach. They don't know what they are going to learn. And everybody is like staring at each other. Let's see what is the next move. Like we are in the boxing ring. What next move? We don't know. Okay. Then human factors. The human factors is like for them, it is ergonomics. How can we make our work and our junior work easy? That's what should be asking. It is not like you do this, you do that, then it will be no work done sincerely. So ergonomics is very important. Human factor. What are your requirements? Tell me your requirements. He says I can work best doing this shift. Maybe I can take care of airway better. And we said no, you go and put the chest tube. And the person who is expert in putting chest tube, no, you go and take care of the airway. This happens in government sector. I mean, person who is qualified for some subject are not given that subject. So human factor, they are dirty dozens by Gordon Dupont. He was working in Canada. So please just go through I mean, something funny. I am going too much overboard. नहीं मैं सोचा कि जैसे हम बात नहीं करें तो इसलिए to visit Yamunotri. So they come and arrive around approximately say 7,000 feet. They come, they stay, they sleep, and next day, and one of them, you are there, you are there, and who else? हम चार आ गए. We are from Delhi. We will imagine. Let's see. Additional contact. Okay. Oh, very famous name. Okay. So we have arrived at 6,000 or 7,000 feet. 7,000 feet. Okay. So we have arrived. We slept. Good sleep. Good food. Everything goes okay. We are cheerful that we are going to climb next day. Approximately 500 feet. Okay, next day, 4 of us, we are up in the mountain, approximately 500 feet. We do that, we come back, and then again from 500, we go to another 500. Now we are sleeping at 7,500. Okay. But I could not sleep that night. I could sleep at 7,000, but not at 7,500. Okay, Dr. Mukada, he said, I'm not feeling like eating something. You have some kind of rose. Okay. Then you are the doctor, you say everything is okay, nothing doing, we will move higher up. Okay, so we also ignored. So this happens because we are coming from Delhi, maybe we have tired, we have come so long, so we are tired, we are fatigued. So we continue. Now we go to 8,000. Okay. So now we sleep. You are in the journey, you are imagining. Everybody, like we sleep again at 8,000. But next day, I have started severe headache. You told me to take paracetamol, but it's still there. And you are not eating anything, you are vomiting. Okay. And you are feeling not cheerful. On day one, you are very cheerful, but you are feeling now I am very tired, very fatigued. Only Dr. Shobha is cheerful because she is a tracker. She goes to small mountain like 5,600, you do some trekking. But three of us are not very cheerful. We are not. So something is wrong. Like I have read an article. We are not medicals. You are the doctor. So something like a mountain sickness was in my ear. ये तो नहीं हो रहा कोई, something like that. Then yes, it could be. So the initial symptoms are very mild, and we should not ignore them, especially when we are not used to how high mountain. Because of course we live in plain. Our ancestors used to live in plain. It is million of story. We have been living on plain, and suddenly if we go like 6,000, 7,000, 8,000, then our body definitely doesn't get acclimatized. So you have to prepare. But again, coming back to our scenario, pilgrims don't have time to acclimatize, and they come in the last years of their life because वैसे भी ऊपर जाना है, so it becomes nearer. So we don't do that. American or the English people, they prepare before they go trekking. They have so many things to do before they go trekking. But here we are talking about not the mountaineer, but our routine friends, pilgrimage who comes have good time. So initial symptoms are very mild. It could be if we start from the head. Let's imagine. We are imagining everything from the headache to nausea, vomiting. Why we have nausea and vomiting? Because of the gaseous discharge of the gastrointestinal tract. Because as we go higher up, the pressure goes down or goes up. Goes down or up. जैसे जैसे ऊपर जाते हैं प्रेशर कम होता जाता है. ओके, तो लाइक वी विल इमेजिन कि हाँ थोड़ा सा हेडेक होता है, वॉमिटिंग बिकॉज ऑफ देन फैटीग, टायर्डनेस. ओके, दीज आर द इनिशियल सिम्टम्स. So usually they are controlled by either paracetamol or Diamox. We will talk about Diamox later on. Why? So then, suppose we took paracetamol, he took ondansetron and Panto. So we got all right, and then we started again ascending. Now we are at approximately 9,000. And then who was having headache? Me or you? You are not in the story. So, I was having headache. Then I have very severe headache, caustic headache, not going away with paracetamol, and then I have severe vomiting. Okay, so now there are chances that I could be having high altitude, or now he is having severe breathlessness, so he could be having high altitude pulmonary edema. I don't know. I'm not sure which comes first. But as I have read the literature, it is high altitude HAPE, and then it is HASE, because HASE is absolutely fatal. So we have to be careful about these two entities. Okay, HASE and HAPE. So like Dr. Nagati has discussed shortness of breath. But clinically how we do that? Like we are drinking tea, but I am not able to drink. But like I am having breathlessness even while I am talking. I'm not able to complete my sentences. I'm not able to drink my, tea or coffee, whatever. I get breathlessness. So that is the point. We must start thinking in terms of, like, probably we are having this high altitude pulmonary edema. So initially there will be dry cough. We know all the symptoms. But here the concern is when somebody starts showing pink frothy sputum. But before that, I think now there are facility available. Now we will find from you who are working Yamunoti and Badrinath. So how often the patient comes with pink frothy sputum? But come with breathlessness, dry cough, fever. There could be mild fever also. It's not pneumonia. Even HAPE can lead to fever. Okay, so we have to be concerned with these two, HAPE and HASE. Okay. So now, of course, these are the common. But why these two things happen? As a doctor, we should know. So if we talk about physiology, so our blood to the brain is auto-regulated with the baroreceptor and the brain stem. So these two things we have to keep in mind. The carotid baroreceptor, the sensor, and the brain stem. And the kidney. So they maintain our pH. And this is how our ventilation is controlled. So as we ascend higher up, what happens? We hyperventilate because there is less oxygen. We have to have more breathing to get same amount of oxygen. So that's a natural phenomenon we have, hyperventilate. But when we hyperventilate more, what happens? The carotid sensing goes off. The brainstem start responding. So what happens? We hyperventilate, we wash out carbon dioxide. So there is what? Alkalosis. So what kidney does? It will throw away all the bicarbonate. So this is how things are maintained. But when autoregulation is off, then the blood goes into the brain. Larger amount of blood, more than what is required. So there is an edema. So initially it is a vasogenic edema, but interstitial edema. But later on, the blood-brain barrier is also broken. And then there is the place where you have florid edema and it will fatal. So this is like